Okay, I'm going to be talking to you about mazes. Now, mazes are, I'm still thinking optimization, but now I'm not doing optimization for the patient-facing intervention. I'm over here doing implementation science I'm optimizing an implementation strategy, which are also interventions, but their goal is to get an evidence-based practice into practice, okay? So here's what I'm gonna try to do. I'm gonna put you in the shoes of an implementer for about these 2 bullets. I'm supposed to do it in 5 minutes. I'm gonna put you in the shoes of an implementer. I'm gonna introduce mazes, and then I'm gonna have you come back and become a researcher. So I want everybody right now to take off your researcher hat and put it on the table for 2/3 of the time. Everybody got it? You're no longer a researcher until I tell you so. Okay, here we go. All right, this first slide is just jargon. In the world of implementation, we have levels, right? Because you have systems, you have clinics, you have clinicians, you have patients, right? And a level is nothing more than nested collections of targets. So if you hear me say the word targets, and I'm thinking at the clinic level, these are my targets at the clinic level. Everybody with me? I'm just getting some language down. And in implementation science, this is important because we're going into clinics and systems trying to get interventions in there. Everybody with me? So the slide I don't need for many of us is there's many barriers to implementation. Linda already spoke to us about one major barrier, which is the intervention is impossible. Okay, right? So don't even bother trying to implement that thing. Go back and redo it. Here, we're pretending that we have an intervention that's already implementable. Maybe it's even been optimized, okay, using these methods. And now we're looking at other barriers. Okay, you with me? And the other barriers could be at the system level, we have ineffective communication. At the clinic level, we might have a lack of support or workflow processes, right? Inefficient processes. Or at the clinician level, we might have lack of skills, right? And implementation strategies try to tackle these problems to get the intervention. So like implementation scientists call them implementation strategies. That's a fancy word, but it's just an intervention. You guys with me? It's an intervention with a different objective, okay? And so like if you have ineffective monitoring practices, you have things like audit and feedback. If you have lack of support at the clinic level, you have facilitators. If you have lack of skills, we often think about coaching, right? Coaching in a new practice. Everybody with me? All right. So this is the lay of the land. Okay, remember you're in the shoes of the implementer. And from your perspective, things look really tricky. And the reason they look tricky is there's like 100+ different strategies that all of us are generating and putting into our journals. But different clinics might need different things. Different levels might need different things. So this is a really tough situation if you're an implementer, right? Remember, for now, you guys are all implementers. This is really hard. And here is the actual challenge, all right? Not enough for me to just tell you it's hard and you have to believe me. The challenge is that at any one level, suppose I'm at the clinic level, what works for one clinic is not going to work for another clinic, right? Like clinics, they're serving different populations, they have different MDs in place, they have different pharmacological experts, right? Clinics are very heterogeneous, even within a system, all right? So what works for one clinic may not work for the other. And that's happening at all the levels. What works for one system is not what works for one clinician. You guys with me? And then what works in the short run may not work in the long run, or vice versa. So these are what I call between target heterogeneity and within target heterogeneity. And this is happening at all the levels. That's why I say things look tricky. How does an implementer show up to a system and then start intervening to get the evidence-based practice adopted? All right, multi-level adaptive implementation strategies, otherwise known as mazes, are one possible solution to this, okay? And I'd rather just show you a picture. Let me just show you a picture, okay? So in the state of Michigan, every high school in the state of Michigan has at least 2 school professionals, or at least one, whose sole job is to provide mental health and substance use services to all the kids. That's already in place in the state of Michigan. Every high school has at least 1, up to 4, and it depends on the size of the high school. Everybody with me? We're not changing that, that's already in place. And did you guys know that schools are the primary provider of mental health and substance use services in our nation? Did you guys know that? But did you guys also know that when we looked in there to see what the school professionals were doing, 3% of what they were doing was evidence-based. Okay, so this is like a classic, like, kaboom. Like, we need implementation strategies, right? We need to figure out a way how to bring the schools up to speed, right? So in the state of Michigan, here's what we did. This is an example of amazing. This is an example of one implementation strategy. We show up at the Holiday Inn and we have a weekend training, and it's district level, so at the county level, we invite all the school professionals from all the high schools at the Holiday Inn, and we have a 2-day training. But it's more than just the weekend training. We give them website access. We give them a newsletter. You know, we're trying to engage the school professionals and the school leaders. We have a monitoring protocol, because guess what? We're going to be checking in to see how they're doing. This is all happening in 2 days at the Holiday Inn. And we have a technical assistance phone number, and we say, here's your phone number. Call me if you get stuck. What do you think actually happens? Very few people call. But that's okay. It's there. It's good, right? You know, okay? And this is considered a $2 sign intervention. Okay? This 5-component strategy is considered a $2 sign implementation strategy. At week 12, startup schools, these are schools with school professionals that have no training in CBT or have never provided CBT to any students. Now you might wonder, how did you know that? How did you know that at week 12? Well, remember, at the Holiday Inn, we onboarded them to a monitoring protocol as part of REP. Remember that? So remember, you don't have a researcher hat on right now, none of you. There's no research happening here. This data is part of the strategy. And for schools that are startup schools, according to that definition, we say they need coaching. And coaching is $4 signs. And this is what we actually did. We actually, all the way up to the Upper Peninsula of Michigan, we had someone drive in person to do CBT skills coaching. Cha-ching, 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 cha-ching. If you're the state of Michigan thinking about actually doing this, Maisie, you're thinking, how much is this gonna cost? All right, and they show up at the school and they help you and they watch you do the CBT and then they give you feedback. Are you guys following me here? Coaching is extremely expensive. That's why I put $4 signs. Everybody with me? All right, but I knew enough to only give it to the startup schools. Right? So there's some thought that went into it because this is amazing. You guys with me? Okay, all right. And then at week 21, remember, we're still monitoring them, right? At week 21, we can see how they're doing. Week 21 happens to be right after the holiday. Great. So a slow responding school is any school in which a school professional reports not providing 3 or more CBT components, more than 10 students. That looks complicated, but I just need y'all to know that that is a low bar. I mean, that's like almost 0. Because we already know from prior research that many more students need CBT, okay? So just, and in your mind, just think this is like almost just barely doing any CBT, okay? Or the schools report lots of barriers to delivery. So they might be hitting a home run and doing CBT, but they still have barriers. You guys with me? That's happening at week 21. And if you have barriers, you're a slow responding school, we're gonna add facilitation. Now facilitation is only $3 signs, because it's done over the phone. All right, remember that technical assistance number we gave them? And we said, call us if you get stuck. Well, that's what facilitation is, but instead of being half a penny, because all I did was give you a business card, it's $3 signs because now I'm calling the school proactively. That costs money, right? Because now the school is on my docket and I'm calling, right? You guys see what we're talking about here? And the other thing is, whereas coaching is about skills, facilitation is about what I call business level barriers. Like, believe it or not, you guys, we actually had some school professionals say, the principal doesn't even want to give me a room to do CBT. Oh, yes. This is what we're dealing with. The facilitator is basically coaching them on how do you deal with a principal like this? How do you talk to them? You know, that's what's happening here. Everybody with me? All right, why Maisie's? This is the significant section of your NIH grant. I don't have time today to go into all these, but they're deliciously interesting. Timing is important. So not all clinics, not all schools in this case adopt at the same rate because of the makeup of the school. Strategic sequencing, you might want to be thoughtful. Do I do this first or do I do that later? These are all reasons why you might need health equity. Billy taught me that adaptive interventions, everything we've been talking about today are consistent with vertical health equity principles. Why? Because if you have a fixed budget, and you're doing an adaptive intervention, you're putting resources where they're needed to achieve an objective, right? That's actually vertical, that's one of the principles of vertical health equity, all right? Engagement is critical. We don't sweep engagement under the rug. Engagement might actually be the reason you adapt. I didn't use that here in this example, Maisie, but if you're having webinars and you're having trainings and you're doing all this thing and no one's showing up, it's time to change what you're trying out, right? So engagement is critical. My favorite one, more is not better, often. This actually keeps rearing its head throughout my whole career. Like the last 20 years, this thing just keeps rearing its head, and I'm going to show you some results where it rears its head again. And then resource efficiency, which Linda and Julia. You guys doing okay? I have 5 minutes left, and I'm ready for the last part. Put your researcher's hat back on. You guys ready? And hold on, because I still have a bunch of slides. All right, and I'm okay if I don't get through all of them. You'll just email me, or you can talk to me later. I'm here all week. All right, now that you have your researcher hat on, the only thing that makes us different as researchers is we ask questions and we want to answer them rigorously. That's it. That's it. And so we have a bunch of questions about how to make a really good maze. That's optimization. We have a bunch of questions about how to make a really good maze. Not, I just want to know if this maze works. That's evaluation. That's not what we're talking about today. Optimization. I have a bunch of questions to construct a really good maze. And I have 13 of them. I probably won't get to all of them, but let's see how far we get. I call these the basic four. The effectiveness of early strategies, of later strategies, like the effectiveness of coaching, which came early, the effectiveness of facilitation, which came later, right? You might want to know that as a scientist. It's up to you, right? You generate the questions. Or you might want to know how they interact. Like, is 1 + 1 = 5? Ideally, coaching and facilitation has a positive synergistic interaction. Or you might actually be asking an even more fundamental question is, do I even need to do adaptive? Maybe instead of mazes, we do missies, right? And we designed the trial to answer exactly these questions. Now, one thing I didn't tell you that I should have is why is the maze that I showed you early multi-level? And I shouldn't assume this is obvious. It's because I have components at different levels. Everybody see that? So rep is at the county level, and coaching and facilitation are at the school level. You guys follow me? And I forgot to say that. It's critical. So, but these questions so far, if I think of them in the context of coaching, like, do I need coaching? Do I need facilitation? What's their interaction? Do I need to adapt? At this point, these are all at the school level. They're all at the same level. You see that? And so I can design a trial, an optimization trial, just like Billy taught us, to answer these questions. This will give me the effectiveness of coaching. This will give me the effectiveness of facilitation. You see that? I'm randomizing schools over and over again to whether or not they're going to get these interventions, and it'll help me understand their interaction. Are you guys following me? The other cool thing I need you to think about, and I wish I had more time to lay it out for you, is inside this study, there's 2 mazes and 2 missies. I'm going to do this really fast. You ready? Some schools, not a multi-level implementation strategy, not adaptive. So some schools, here, watch this. You'll get it with this. Some schools only ever get rep. There's nothing adaptive about it. You guys see that? Some schools get rep and coaching. Nothing adaptive about it. You see, I randomized all the schools. You guys see that? So 2 of the embedded interventions here are not adaptive. But then there's 2 that are adaptive. I didn't give coaching. I was a slow responder and I had facilitation. That's adaptive. I just didn't have coaching. And then I have the Cadillac. I did coaching. I'm a slow responder. I added facilitation. Everybody with me? And what do you think the primary aim was in this study? I have 4 strategies. What do you think the primary aim was? The Cadillac, rep, coaching, if you don't respond to facilitation, versus rep only. That's how we size the trial. We chose the sample size for the trial. And on our website, we have clustered, we have power and sample size resources. You can go do this all on your own. We have little apps and everything, okay? Now, I'm gonna show you results, and this might be all I have time for. How many minutes do I got left? 30 seconds? 3 minutes. All right, I'm gonna show you results of this trial because it's amazing when you wait this long, 5 years to get results, and they're so delicious. All right, so let me orient you. Our primary, and this is our primary aim analysis. This is the first paper out the door. Our primary goal was deliver CBT to your school professional, right? So it was a quantity thing. Why quantity? Just remember where we're starting, okay? So a lot of implementation scientists want to debate, oh, quality versus quantity. That's okay, but guys, there's no conversation about quality here. They're not doing anything ever. You know what I'm saying? Okay, so and the primary outcome in this trial was, did you deliver CDT at the level of the school professional? That's called a clustered outcome. The school professionals are clustered inside of schools. Everybody with me? So this is a very novel SMART indeed, right? It's a clustered SMART. Okay, you guys with me? That's the y-axis. The x-axis is time. And this is where we added coaching, this is where we added facilitation. So a lot's happening here, and then we had a follow-up. Is everybody with me? All right, you guys ready? And then one more thing. If you see a circle, that's the non-adaptive. So this blue is I always gave rep. This green is I always did rep in coaching. State of Michigan would love to just do rep. It doesn't cost much. All right, check this out. Our primary aim, right there. No difference. Okay? No difference between the Cadillac and but lucky for us, we baked in some other questions, right? This is an optimization trial. And to write this paper, you know, there was insufficient evidence to reject the null that, you know what I mean? It was fun because we had this other part, this other story we could share. So in this trial, on average, rep plus facilitation is better. Now, question for all of you guys. Does this mean we shouldn't do coaching? Why?
Benefit from that method.
There might be schools that benefit from coaching. Guys, that's the point of optimization trials. So we're currently writing other manuscripts where we're trying to figure out which are the schools that need coaching, and we're hoping to see a mean up there. Because that could happen. That could actually happen. That's the point of optimization trials. If we discover that startup schools, remember my conjecture, are the ones that need coaching, and we end up with a mean that's up there, then I will say to the RCT folks, let's confirm and evaluate that one in the next RCT. Okay, I think I'm out of time, but I want to let you guys know that another part of this area of science, which is deliciously interesting, is that many of our randomizations, they don't always have to be at the same level. So we're writing manuscripts right now where we're grappling with the causal and statistical issues on what happens if you have one randomization at a district level and another one at the school level, or one randomization at the clinic level and another one at the clinician level. I don't have time to go over it today, but thank you for your time.